Welcome, everyone. My name is Yvette Gaughan. I'm in the Department of Medical Affairs for Nestle Health Science, and I'm going to be moderating today's Q&A session. Dr. Riquelme is currently Director for the Center for Swallowing and Speech-Language Pathology at New York Presbyterian Brooklyn Methodist Hospital. He is also the Associate Professor of Speech-Language Pathology at New York Medical College. He completed his Master's of Science at Columbia University and his PhD at the Graduate Center, City University of New York. Dr. Riquelme has authored several articles on dysphagia, multiculturalism, and quality improvement. His current research includes changes in swallow physiology in people with dementia, swallow differences in the presence of pills, and the impact of dementia severity on swallowing dynamics. At the hospital, he leads the diagnostic practicum rotation completed by all speech-language pathology students and supervises graduate student clinicians completing their externship. He has served on several local and national boards and committees, including Chair for the American Board of Swallowing and Swallowing Disorders, Chair for New York State Board for Speech-Language Pathology and Audiology, and past President of the New York Speech Language Hearing Association. So he currently serves as a member on the board of directors of the International Dysphagia Diet Standardization Initiative, known as IDDSI, and shares his passion for helping people with dysphagia by educating practitioners both locally and international. And we are thrilled to have Dr. Riquelme today. With that, I'll turn it over to you.
Well, thank you so much. Welcome, everyone. I understand we have a large amount of registrants, so thank you for being on the program and here with us today. And I'd like to thank Nestle Health Science for inviting me to do this webinar, and Yvette Gaughan in particular for orchestrating that this happened. So thanks very much. I will certainly make sure that we have time at the end for questions. So let's start with, do you IDDSI too? Let's talk about implementation. If you haven't heard about IDDSI, the International Dysphagia Diet Standardization Initiative, I will tell you that the group started back in 2013, and it's composed of volunteers from several different fields, and I'll let you know. So we are a volunteer board, and the IDDSI framework, as we refer to it, has received support from ASHA, the American Speech Language Hearing Association, and from AND, the Academy of Nutrition and Dietetics. Here's a listing of our sponsors. These are, as you see, we have platinum sponsors, gold, etc., and these are the sponsors that make it possible for the IDDSI Board of Directors to do our business, move forward, and make things available. Also know that everything, all the materials we'll be referencing today, including videos, are available on our website, IDDSI.org. Why this whole concept of starting a new framework called the International Dysphagia Diet Standardization? And it really all has to do with safety. And the concept was safety through common terminology, because when we look at our current diets, or when we were looking at diets, we saw that there were many different terms being used even between facilities in the same town or same city. Also, to have a system that was readily available for all ages, the systems or frameworks that were available really focus mostly on adults, and this goes from infancy through geriatrics. In all care settings was also an important piece for us as we started this initiative, so that we're not just talking about the hospital, the rehab center, or the long-term care facility, but also what happens at home, what happens in group homes, and so we needed to pay attention. And certainly across all cultures. We don't all eat the same way, we don't all eat the same foods, so how could we come up with a framework that worked for everyone? So why do we need this standardized system? The main issue was safety. There have been choking episodes reported around the world you look at coroner's reports, you'll see that they all are related to instances where maybe wrong diets were administered, or wrong sizes of bites were allowed. So safety is a big concern at a global level. The efficiency of being able to communicate with each other. I always use the example of, let's say, the hospital that has a mechanical soft diet, and then that patient is sent to a rehab center where they don't have such a diet. Maybe they have a chopped diet. Well, how do we know what materials belong to what, or what foods belong to what, and which are appropriate for this patient? So now the patient has to wait and be reevaluated for the appropriate diet at that facility. So efficiency was also a big push here. Commercial consistency, as you know, and we learn more every day. A particular product might say, let's say, nectar thick. Well, the nectar thick, when you use a thickener from one company, might be different than the nectar thick that results from using another product. Commercial consistency was important, as well as research. So we have researchers that have reported things like they've administered nectar thick liquids or honey thick liquids, but what's the standard? How do we easily measure those to make sure we're speaking the same language? Okay, so we need evidence for the whole project. And so we started with, first of all, terminology, right? So in 2013, we published a paper really surveying folks around the world. And we received responses from 33 countries, 2,050 responses, as you see on the slide. But the survey wasn't just of professionals working with people with dysphagia, but it actually included people with dysphagia, caretakers, several organizations, food service providers, researchers, industry, as well as professionals in healthcare. And so the results were kind of interesting. So, for example, for food items, we found that around the world there were 54 different names used for foods. And yet, in every country, what was commonly used were 3 to 4 levels of food. Similarly, for liquids, we found 27 different names of liquids. Imagine trying to communicate. And again, most countries commonly used about 3 levels of different thickness of liquids. So on the next slide, we also share that we found that in terms of the respondents, there wasn't a lot of testing happening at the point of service, right? So if the material was modified, let's say in the kitchen, that's where the testing was happening. Nothing was happening at bedside. So who knew what was happening with those foods once they arrived at bedside? So we then went ahead and did a systematic review, as you see here, and all these articles are available open access on our website as well. And so on the next slide, I share with you the results of that systematic review. Originally, the concept really was to see, what do we know about changes in physiology, and what evidence do we have for that? So the original search yielded 10,000 articles. When we checked those for relevance, that boiled down to 488. And then after rating for inter-rater reliability, it was reduced to 36 articles to inform the review. So what did we find? So we kind of knew that thickened liquids help those who aspirate thin liquids, right? Because it's a little slower, etc. But we also found that liquids could be too thick. And our concern, and if you look at, I would say, research that has been published over the last 2 to 3 years, we are paying more attention to the aspect of residue. So what is left over in several of the pockets we have in the throat, the vallecula and the piriform sinuses in the pharynx? So what happens to that residue? Is that residue then aspirated on a subsequent swallow? So those are some of the concerns that certainly come up. We also found that there wasn't much information about how we modify foods. So we know that the more solid the food, the greater the effort in oral processing and swallowing. But again, we have very little information in that area. So this was just right before I joined the board. I was asked to join the board of directors. The board of directors took this information, sat down, put it all together, and said, now what do we do? How do we develop a culturally sensitive, age span relevant framework that will work for us all? And that's how the IDDSI framework came about. Here is the board of directors. I will just go ahead and share with you that we have on the board speech language pathologists, we have dietitians, we have food scientists, biomedical engineer, pediatric occupational therapist, gastroenterologist, otolaryngologist, and let's see, and a nurse as well. Our co-chairs towards the bottom of the slide are Peter Lamb, who's a dietitian in Canada, and Julie Chicaro, who's a speech language pathologist in Australia. So they lead this wonderful group of volunteers and colleagues. The framework really set things up so that as we share this with the world, we look at different phases of development. So first of all, it would be awareness, right? And we've been doing this now for a few years, making everyone aware of why this framework makes sense and why it will help with patient safety. And then now we've moved on to the preparing and adopting, hence this webinar, which is really focusing on implementation. And I'll spend more time on that as we move along. So here's the framework, and if you haven't had a chance to really review it carefully before, I think the beauty of it is that we have foods and liquids along a continuum. We have numbers, colors, and labels for each of the levels on the framework, so it's easily identifiable. As you see for the drinks, let's say somebody that is on a regular diet with regular liquids, that person would be, let's say, a 7-0. But we also have level 1 for liquids, which is slightly thick, and usually the baby formulas fall into that category. And we're finding, interestingly, we had no literature in the adult world looking at slightly thick textures, that slightly thick might be enough to reduce the risk for aspiration in some cases. So that's new emerging research that you might want to be on the lookout for. Level 2, mildly thick, would be the equivalent of what today we call, let's say, nectar. We try not to think of it that way because we want to just incorporate these new labels. However, the truth is, industry right now, if you look at the products that you receive at your facility, are going through that transition. So some of the, let's say, pre-thickened liquids to nectar consistency will say nectar, and next to them they will also say, level 2, mildly thick, so that we start getting used to the new labels. As you notice in the framework, we do have levels 3 and 4 that share drinks along with foods. And that's because it depends on how you are using them. So you have a moderately thick liquid, which let's say we would call honey thick. If it's on the food side, it would be more like a liquidized diet. Okay, the same thing with extremely thick, which is level 4. That would be more like a puree. Extremely thick in some countries was called spoon thick. So that would be then pureed on the food side. So that's sort of why we have these two shared levels noted on the framework. On our website, we have, I would say, there are two really important documents that need to be shared with everyone, which is the descriptors, so the IDDSI framework descriptors, and the IDDSI framework testing methods. So first, we needed to be able to describe every different level, so that there aren't questions of, where do I fit this in? But then the big issue is, how do we test these items, and how do we make the testing readily available to all, so that we can again cross cultural barriers at a global level, so different foods, different interests. And so I'll address that as we move along. Here's just an example. In level one, a description for slightly thick, and then sort of the testing method, which would be in the other manual. So those descriptors are available. The big issue was, how do we measure liquids? And luckily we have a biomedical engineer on our board who actually specializes in liquids. And so the idea was, the truth is we're only measuring viscosity, right? But to truly test a liquid, we would need a rheometer, and rheometers are very expensive. It's not something that our kitchens in our facilities, or definitely not kitchens at home, have available for testing the viscosity, the yield stress, or the density of liquids. So we needed a simpler, valid, and reliable way to really look at liquids. And that's how the IDDSI flow test came about. I, I honestly have to tell you, it can't get any easier. You use a 10 milliliter syringe, and we have a description of which specific syringes are appropriate. And I say that because when we started this, we found out that 10 milliliter syringes are not all the same. It depends where the nozzle is, the length of the nozzle, etc. So our way to really address that, so that we're not promoting one particular brand, would be to check your syringe. If you see the little guide on the left of this little flow test card, it needs to be from 0 to 10 milliliters, needs to be 61.5 millimeters. Okay, if that's the case, then you should be good. We do have these little cards available for printing from our website, and hopefully soon we're going to have those available for purchase. We're looking into how that would happen, because that's what we've heard from many of our colleagues around the world. It would make life a little easier. So how does this flow test work? So the bottom line is, and I'll show you a video in a minute or so, is you fill the syringe up to the 10 milliliter mark with the liquid you're testing, while you're covering the bottom with your finger, and then you let it run for 10 seconds, and then you stop. And depending on how much liquid is left in the syringe, you then can figure out what level it's at. If you look at the slide, look at the red text, and you will see that's how we kind of match that, depending on what is left. These are the syringe specifications. Those are available on our website. And yes, we'll be looking now at the video on the flow test. It is a silent video. We do recommend filling the syringe with another syringe. It makes it easier. And now you go. 10 seconds. Perfect. So see what's left. And there we go. This is a level 1 liquid, so slightly thick. And here we compare the different levels. Silent again. 10 seconds. Look at level 4. And there you go. So level 4, if you remember on the framework, is also puree. So that would be a little difficult to run through. So we recommend then the spoon test for that. And we'll talk about that in a second. Now, when we go to foods, foods are a little different. And so for foods, when we look at the descriptions, they're quite detailed into what the texture is like. So that applies for minced and moist, level 5, level 6, which is soft and bite size. And so those need to be pre-cut to particular sizes. And then 7 would be regular. So we've included in here information on, how you would test it, but also what qualifies for level 5 or for level 6. Now, if you notice in level 5, minced and moist, we're looking at lumps. And based on the size of the airway, because of the choking risk, for pediatrics, if you see bolded here on the slide, the lumps should not be any larger than 2 millimeters, and for adults, no larger than 4 millimeters. And I'll show you a trick in a minute on how we're going to measure that. So this particle size dilemma, again, is really because of the risk for choking. What's interesting is if you think about it, the size of our airway or the size of our trachea is actually about the size of the tip of our pinky, right? That's, if you look at the tip of your pinky, that's about the open tube part of our trachea. That's the size. So it's kind of small. We don't think about that very often, do we? When we're looking at particle size, I mentioned the 4 millimeters for adults and the 2 millimeters for pediatrics. Well, guess what? We have forks, and we have found that all forks, we thought only metal forks, but we've noticed that it's the same thing with plastic forks. As long as they have 4 tines, they are 4 millimeters. The slots between them are 4 millimeters. So that makes measuring way, way easier. Okay, so lots of good practical stuff to use. So that's the beginning. That's particle size. Now, how do we figure how soft something is? So that's when we develop the fork pressure test. With the fork pressure test, place the fork on top of the sample. With your thumb, you put it on the base of the fork and you press until the tip of your nail is blanched. Okay, so definitely if you have nail polish on, that would not be a good day for testing. So you want to see as soon as it blanches, that's enough pressure. What's very interesting, we discovered, is that the pressure required to blanch the edge of your nail, okay, across cultures, we tried many different people, different skin colors, different thumb sizes, and they were all in the range of 17 kilopascals, right? We measured that with the IOPI, the Iowa Oral Pressure Instrument. Okay, that's wonderful because it turns out that the force needed by the tongue to crush a food item against the hard palate is in that 16 to 19 kilopascal range. Transitional foods require a little more reading, but we know about these, and these are really relevant in pediatric settings. Things like potato chips, where it's a solid, but certainly by the time you swallow the potato chip, it is not a solid because you've mixed it with saliva and created a different texture bolus. So here is a little bit on the food testing, and this is what you would do with your menu items at work. Again, it's a silent movie. Does anything stick to the spoon, or does everything slide off? We also have chopstick test. And the finger test. So depending on the patient and how they intake food, you would use the appropriate test. So we're back to, okay, this is all wonderful. Now, how do we move towards implementation, right? So the first thing is your greatest resource, seriously, is our website. And you can certainly communicate with members of the board in the website. We're right now working on figuring out a way for people that are going through the implementation process to have a place where they can share and discuss. But let me just show you briefly some of the materials available. I also suggest you sign up for eBite, which is our monthly newsletter. And that gives you all the updates and all the fun things going on around the world that are IDDSI related. We also have phone apps, and this is extremely user-friendly, available for the Android and the iOS. You can download that even right now, or maybe right after the webinar, because you're paying so much attention. And it's for free, and all the videos are there, all the references are there. Everything you need is in the app. Okay, so implementation. Now you decide, yes, this is the way we're going. The Academy of Nutrition and Dietetics have updated their diet manuals, and they reference IDDSI. And speech pathology says, let's all start talking the same language. Clinical nutrition says, let's start talking the same language. And food service says, well, how are we going to do this, right? So it's manageable. Here are some more resources available. If you click on resources, you then go to implementation, and you then will find these materials. We have posters, conversion charts, some audit sheets. Pretty soon we'll be having some mapping or testing sheets, different labels for when you're going through this transition with some of the food items or snacks that are sent to the floors. You can print out these labels and put them on the items that are going to the floors. There's a specific section for food service. And we also created these implementation guides. So we have implementation guides for clinicians. We also have it for food service, industry, and then just a master guide. These kind of go through, let's say, a 12-month process of how you would start the process of implementation all the way through to completing the implementation process, which requires monitoring, of course, throughout the whole process here. So now you want to do this. So how do we start? Well, first you need to find out who to team up with, right? What we're seeing in many parts around the world is it's usually the dietitian and the speech pathologist. However, there have been places where it's been somebody from food service along with a dietitian, or just somebody from food service that has heard about this and knows that it's the way to go. There are also some countries that have adopted IDDSI and so have created a mandate. Okay, so New Zealand went full implementation earlier this year. We know that May 1st, 2019, AND and ASHA have said would be the implementation launch date for IDDSI in the United States. And that just means that we need to start moving towards implementation. Israel recently adopted IDDSI through their Ministry of Health. So different countries are managing IDDSI in different ways. Canada also last year went full implementation, I should mention. So bottom line is, we're at our facility. Who do we team up with to get this to move forward? The other piece, when we're sort of in this phase of figuring out the moving forward part, is who's going to approve this process, right? So is it a regional administrator? Is it a vice president? Is it a director? Who in your institution is the one that would make the decision to say, yes, let's start moving towards implementing the IDDSI framework, and let's roll up our sleeves and get to work. And then once you've gotten that approval, then who do you engage? Who are the initial stakeholders, right? Because you can't take everybody on at once. So depending on your facility, that might be the clinical nutrition and speech pathology team, maybe not all of food service, maybe just the food service supervisors, for example, to maybe go through an hour long or a 2 hour long IDDSI in service. We have slides available on the website, and where you also practice the flow testing and the food testing and get the major stakeholders engaged and involved. The next question, once everybody agrees, yes, we're going in this direction, we have administrative approval, would be, well, now what do we do with our menus? That's what we call the mapping process. So mapping all the menu items has been done in different ways by different facilities, again, around the world. I know that, for example, in one facility, they created a team of 3 speech pathologists, 3 dietitians, and they took on the full menu and started testing all the food items and putting them into the different it's the levels on the framework. At other places, what we've done at our hospital is actually we created 6 teams of 2 people, one dietitian, one speech pathologist, 6 teams, and over 6 weeks we laid out the menu. We worked with our executive chef, laid out the menu so that we knew what food items were available, and then had every team sign up for 4 shifts, whether it was breakfast, lunch, or dinner. And then they'd come in, we had the items ready in the kitchen, and they would start testing for that particular meal. And that's how we were able to map 296 items in 6 weeks. That was very helpful in terms of getting everybody engaged and making it user friendly and getting everybody to practice. While you're doing this, I suggest that you look at doing some inter-rater reliability, where someone else comes in and double checks about maybe 15% of the items, just to make sure that everybody's on the same page. I think a good way to then just match the menu items with the IDDSI levels. So once you're done with that mapping, then I think some of the issues really have to do with how do we start training others, let's say nurses, the physicians that will be writing the orders, others that might be engaged on the floors. And then we have to allow some time for that to happen. So this, for example, is what some of the diet orders might look like, right? A 6-0 or a 4-2 would be some of the diets possible. What's really great about this framework is that it's also clear that the patient doesn't have to receive only one texture. Because of the pyramidal shape, if somebody's on level 6, that means they can also handle level 5 and they can handle level 4. Okay, so it's just like on a regular diet, we very often on our plates have a solid. We might have a puree like a mashed potato, and we might have some other grainy texture like a hard vegetable or something. So it's the way we eat. So somebody that needs texture modified diets, following this framework would also benefit from that. So when we look here, we have then someone that is on a 6-1. But if you notice in terms of foods, they have level 6, 5, 4, 3, and then 1 for liquid. They don't have any zeros, but they do have level 3, right? The vegetable soup and the decaf coffee. So that's, I think, certainly a positive in terms of texture modification. This again is just moving us through this process. A big piece is, can the kitchen handle the transition, right? It depends on what system is being used and looking at the computer system. I will tell you that all the major computer systems available to food service now have abbreviations and easy ways to transition to the abbreviations for IDDSI. So it should not be a problem. We need to work on the how do we work on the diet orders and the electronic medical records. Now all this all these items need to start being addressed. And looking at your facility, thinking about how do we bring in the physicians, the nurses, other frontline staff as well. We also recently created handouts and some brochures for caregivers and for patients because they'll go home. And if they're on a texture modified diet, we want to make sure that they understand how to do some of the testing and can check on that without having to call us back, for example. Decisions also at a big level. Does the whole facility implement at once, or do you roll it out first just on one unit? It depends on, again, the culture in your facility. We have posters available on the website. I don't have here, we have a new one that actually has testing and the framework and everything all in one poster. So that is certainly easy. This is a little bit of what I talked to you about. I think right now, what we struggled with a bit, and we've learned from other people around the world, is what equipment to use for minced and moist and for some of the pre-cut food items in level 6. And for that, I'll tell you that we're using a dicer. And so far, we've been testing that, and that's been working out quite beautifully. We also created a newsletter at our hospital to just share what's going on. We send it out quarterly so that people in our hospital, as well as in our network of 10 hospitals, are all up to date. Our hospital was chosen as the pilot site for the 10 hospital network, but I know of other hospital networks where they're implementing at all their sites at once. Okay, so it's that time. Let's see what questions we may have out there.
All right. Thank you so much, Dr. Riquelme, for a very informative presentation. A lot of good information. Hopefully, it's giving a lot of food for thought amongst the individuals that are attending today's presentation. We do have quite a few questions that are starting to come in, so I will do my very best to try to get to as many as possible for the time we have remaining. So our first question that came in earlier during the presentation, Luis, is can a person on an IDDSI level 4 puree also have thin liquids? We do have some residents that are kind of their diet per the SLP order that follow this. So again,
Yeah.
can a person on an IDDSI level 4 puree also have thin liquids if the SLP's order identifies this?
Right.
And how would
So
you
let me
write that
just
diet order? And I know you talked about that a little bit towards the end of your presentation that came probably after this question was
right.
presented. But I
Let
think
me
it's a good
just
question
mention
to
there.
review.
Let me just mention there that the IDDSI framework is to accommodate to what you have available. IDDSI is not a diet, right? So that decision of what the patient can tolerate will be made by the clinicians involved in testing the patient. So if the speech pathologist thought puree with regular liquids works, then it would be a level 4, so it would be a 4-0. If physiologically the person can handle needs puree, let's say because of their chewing capacity or for other reasons, but can handle regular liquids, then 4-0 is totally fine.
Okay, thank you for that. Our next question, Kelly is asking, in regards to level IDDSI level 7, easy to chew, are two consistencies allowed? So the diet information may say that it includes mixed textures, but the handout that they have for consumers states cereals and fruit to be drained. So is the intention of this diet just to address chewing and not swallowing difficulty?
Right. We're just finishing up the artwork, so I didn't say much about the level 7 easy to chew, but there's level 7 regular, right, which is just our regular food items. Doesn't have to be pre-cut, no special precautions. However, as we all know, there are some patients that do not present with swallowing disorder, but maybe don't have their dentures, right? So there are some items on the level 7 easy to chew that are chewable, and so someone without dentures doesn't automatically have to go to puree. And that's the idea behind the level 7 easy to chew. We should shortly have, and I think in the next eBite newsletter, we'll have more information on that. But that really was at the request of many dietitians and speech pathologists from around the world.
Okay, great. A second part to this question. So also for the same diet, the IDDSI level 7, it states to avoid sticky mashed potatoes and dry cakes. But both of these foods would easily pass the fork test. So I guess in this particular situation, this clinician writes the menus, and she finds these guidelines a little bit confusing.
So the issue, for example, is things like a dry cake. It really depends on what you're serving, right? And so that's why we talk about the testing methods. And in this case, I'm glad that the person asking the question, has tried the fork test, because sometimes we have a sponge cake that's nice and moist, but other times we have a sponge cake which is very dense, very dry, and yet they're both sponge cake, right? So that's where then the fork test comes in. And so is this going to be easily manageable versus this other big dry thing?
Okay, thank you. We do have a question here from Jordan. He wants to know, could a person on a IDDSI 4 level 4 diet, puree diet, be allowed to have transitional foods? So they have a resident in particular that's on a puree diet, and this resident likes to snack on their own types of snacky foods, such as
Right.
veggie straws and crackers.
Right. So again, it's up to the clinicians evaluating the patient, right? If the patient can handle level 4, then if you think about it, if we use the quick example of potato chips, not that that's a snack that I think our facilities provide too often, the patient will mix it with saliva, and by the time they swallow it, it probably will be a level 4. But we haven't done that's kind of difficult testing if you think about it, because in order to then check what the patient's about to swallow, they would have to spit it out and we would have to test it. So that's research that hasn't happened yet. But for the transitional foods, yes, I don't see why. Again, if it's clinically appropriate, then go for it.
Great. Okay. Thank you. Here's a question, very interesting and really exciting in regards to the IDDSI app. Is the IDDSI app, is this patient friendly?
Yes, yes, that's the idea. So caregivers and patients will have the information readily available as well.
Fantastic.
Oh,
Okay.
yes. And in simple English as well. And we've had volunteers from around the world translating the descriptor manual and the testing methods manual. Right now, we have 8 translations completed to different languages, and those are on the website under the translations tab. And by the time we're done with everybody that's volunteered so far, we will have 30 different languages available with this. So we're definitely looking to make it accessible around the globe.
Wonderful. I have a question here. Louise, if you could share with us a little bit more specifics about your dicer equipment and what you're using at your facility.
I knew that would come up. So,
Yep.
the dicer, I think it's like the super dicer, miracle dicer. I just know that it's adjustable for the different size, and that's what our kitchen right now is playing around with. What we found when we did our mapping of the 294, I believe, menu items was we ended up with not many items available in level 5 or level 6. But there were lots of items we tested that, because they were not pre-cut, they ended up in level 7, right? So now we're looking at pre-cutting them and seeing what happens. The reason is, it has to do with how the protein breaks down, et cetera, et cetera. So we're using the dicer with the metal blades and playing around with the sizes. So we're experimenting now with that. And then for level 5, it seems like a lot of people are using the buffalo chopper, but I know there are some other choppers available out there for the level 5. So again, you would play around with with the preparation. Where the IDDSI board of directors has had this chat, and we're hoping to get some more chefs involved and food service folks involved, so that there could be a little more sharing about how to prepare certain foods to then reach certain levels. Because I think in the end, it's just going to give all our patients a lot more variety and a lot more gusto for these modified diets.
Okay. We have a question here. It has to do with sharing of menus and recipes when mapping over to IDDSI and being a board member of IDDSI. Are there currently any resources on the IDDSI site or plans in the near future to share at those facilities that have already implemented and done all of the work with mapping over to IDDSI to share their menus and recipes?
So we would love that sharing for people that want to do it, and that's what we're talking. We've actually started the conversation with AND and with ASHA that have way more money than the ITSE board of directors does, because it would be so great to and then involve the food service people as well. It would be so great to have some kind of forum where we could do all the sharing, right? I mean, why reinvent the wheel? and and so we're trying to get out there in the resources tab on under implementation, um, as much as we can. But we just recently added a section under implementation of sort of like materials used by others, and so some people are sharing some of the materials they're using. We would hope to have a kind of forum like that for things like recipes and as well as equipment, for example. And we don't have that yet.
Sounds like stay tuned. I'm sure there will be many opportunities to share, and I know a lot of people will appreciate that sharing as well.
Oh, yes.
I have a question. How are you handling bedside testing of liquids? Is this handled by your nursing staff, or can you elaborate?
Okay, so we had and there's a paper on our website of the Kempen project, where we rolled ITSE out in a hospital in Germany a few years ago to kind of figure all that out. So we do the clinical testing. We recommend what level diet, right? Um, and so let's say if it's a specific level of liquid, let's say it's a level 2, which would be nectar thick, that would be prepared the way we feel it would result in a level 2 based on the testing that's been done. What the flow test allows is that then, probably as a performance improvement project, we can go back and test them at point of service, at bedside. But the truth is that in any event, let's say a relative brings in this juice and now we're going to thicken it, or a juice that they think is thick enough. Any nurse, any nursing assistant, any physician, any dietitian, any speech pathologist, any caregiver could just pull out the syringe and do the test and figure out if it's at the right level. That's what we're aiming for.
Okay. And then I realize we're getting close to the hour here. I want to ask one more question, and then we have so many questions that are coming in right now, that we'll take this one, and then I'll do our concluding remarks. But I understand, Dr. Riquelme, that you have additional time, maybe to stay on for an additional 10 minutes. So for those that can, I'll continue to ask a few more questions. So just to wrap up before I conclude. Again, kudos. Thank you so much for all of the hard work, for the groups and IDDSI and pulling this all together. Can you go over again the concept, if level 6, so if IDDSI level 6 works, does that mean everything underneath IDDSI level 6, so level 5 and 4, etc., that those would work as well?
Correct. So let's say level 6, soft and bite-sized, right? So this is somebody that might have, let's say, something soft like baked fish, but it's pre-cut. Okay, so they can also have, let's say, minced and moist, let's say, pumpkin, which is level 5. They might have some mashed potatoes, which would be level 4. Okay, so you see how then this could be a plate with different different textures which match up with different levels. So anything under in the foods, anything under in the liquids, anything above. That's why the triangles are positioned the way they are. Does
Okay.
that make sense? I
It
hope it
does.
does.
It does. So again, I'll just make this announcement that I'm going to conclude. However, for those that can stay on for an additional 10 minutes that you would like to hear the Q&A, feel free to do so. But I just want to make sure that I address the next steps for those that are interested in obtaining a CE certificate. And for those, we want to respect your time and we know if you need to get back to your practice. So again, thank you so much, Dr. Riquelme, and thank you to our audience. We do appreciate everyone's participation. And for those of you that need to leave, we certainly understand and respect your time. And for those that can stay on, Luis, I have a few more questions that I would
Sure.
be happy to ask you for maybe like another 10 minutes.
No problem. Let's do it.
All right, let's do it. Okay. Here's a question. So it's kind of a sharing too, if you have any experience based on implementation at your facility. So I was told that nursing staff would need to reflow test each fluid prior to feeding the patient. However, if the products are all mapped before, this seems unnecessary. What are you doing at your facility?
So I love that question. That is so practical. So again, a decision would be made about, let's say, the first week of rollout or the first 2 weeks of rollout where liquids will be, or a certain percentage of the trays, let's say 20% of the trays or maybe even 50% of the trays, where the specifically, let's say the liquids will be retested. Each facility is different because in some facilities they will thicken items in the kitchen and then they come up to the floor. At other facilities, the thickening happens at bedside. So, it depends on that model. But even with that, I think a good performance improvement project would be to ensure the consistency of what's ordered with what is received. And that would be done again, depending on what collaboration is going on. It could be done by nursing. It might be done by the clinical nutrition team. It might be done by a collaboration between clinical nutrition and speech pathology. It all depends.
Yep. Wish it was a clear path, but a great opportunity for lots of discussions and getting those committees together.
Correct. So that we can
Here's a
all get
question.
along. That's the idea.
Yeah, exactly. Yep. Here's a question that's more specific to pediatrics. So, how has your hospital operationalized the 2 millimeter diameter for your pediatric patients?
Yeah, so that's a rough one. Again, in pediatrics, a lot of transition foods are being used. So right now, because the pediatric part of our 640 bed hospital is a small chunk, that's sort of on the side for a little bit. However, we have two pediatric hospitals that for sure have implemented completely. That is Connecticut Children's Hospital and also Orange County Regional Children's Hospital. And on our website, we actually have a free webinar available that was recorded by the team at Orange County Regional Children's Hospital. So with all the details specific to mapping with children's food items and transitional foods, etc.
Yes, I will add, I definitely I viewed that particular webinar, and I think it's extremely helpful. So for those that may have not had a chance to view that, I
Yeah.
think it will address a lot of the questions that you have specific to your pediatric population.
Yes, definitely. We're learning more and more each day.
Yes, we are. Yes, we are. I do have a few questions kind of under the same overarching topic here, and it has to do with mixed textures. So, for example, at your facility, can you share how you are identifying thick soups, or there's another mention of like a mixed consistency such as fruit, a fruit
Right.
cup that's in juice. So in general, when you have these mixed consistencies, how are you recognizing those
Right.
from an
So
IDDSI perspective?
that's a great concrete question. What first of all, we definitely would not want mixed consistencies within the same food item, right? So, for example, a soup that is a broth with vegetables in it would not comply with the framework. It would be a level 7. But when we look at things, and I think the fruit cup is an excellent example. So the fruit cups, for example, come in syrup. So that's a mixed consistency. So right now what we're doing, and again, it depends on the volume at your facility, the fruit cup is being opened, the syrup is poured out, and then the fruit is being repackaged in another little container on the tray.
Okay, thank you.
Yeah.
Our next question, for the New Zealand and Canada teams that have been using the IDDSI system, are you familiar with any research yet that's available or coming out, or if they're monitoring this, to share if they're showing a decreased incidence of aspiration pneumonia with IDDSI in place?
Well, again, ITSE's not going to give you that information because it depends on the clinicians that are recommending the consistencies, right? So ITSE is a way to test the consistencies and what you have available. It's not going to tell you if this patient should be on a level 1 or a level 0 of liquids, for example. That's up to the clinical team at the facility that conducts those assessments. Um, Now, there are facilities right now looking at other, outcomes. And so again, it depends on what's relevant at your facility, right? At some facilities, they're looking at food tray errors as an outcome. At our facility, that didn't work because our food tray error rate was very low to begin with, so that wouldn't be a good reason to transition over. We're kind of seeing how food, the levels carry over when they arrive at the floor. That's what we're talking about starting. That'll be happening actually in a few weeks. Yeah, but it won't. I think pneumonia wouldn't be a good outcome to look at because ITSE not an approach to testing. ITSE is a way to categorize and foods and textures.
Okay. Here's a question, and I receive this from time to time as well. So, at your facility, how do you handle or account for liquids that have been thickened, but may thicken, of course, over time? And so, if they're brought up to the patient at bedside and they're kind of left there, and it could be quite some time as the patient is consuming it. Do you have any guidelines or policies in place of how you manage that when thickened liquids
Right.
are going to be sitting out at room temperature over a period of time?
Also, excellent question. First of all, you need to know what thickener you're using, right? So if is it starch based or is it xanthan gum based? Many commercial thickeners have transitioned over to xanthan gum. However, starch based still exists because I know in food service the kitchens use it sometimes for thickening foods. But at least for liquids, I hope not many places are still using starch based thickeners. Those, within a few minutes are already changing the consistency. So now with the xanthan gum, what some of our colleagues in research are pointing to and starting to try to look at is just that. How so supposedly initially when xanthan gum was first brought to this country, introduced in our market, I would say about 10 years ago, the idea was, oh, it won't change consistency once you thicken. So you thicken a liquid, it'll remain that same consistency over time. Well, then we discovered that it really will hold that consistency for maybe 40, 45 minutes. The truth is, it depends on what we're thickening because there are some things we might thicken that will start changing consistency within 20 minutes. And so that's again when the flow test comes in very handy for you to check what's happening at the point of service, what might be happening during a meal, because it depends on one liquid, right? You thicken an apple juice, right? And so that might respond very differently than if you thicken orange juice. So it depends what you have available. It sometimes even differs by brand of liquid. So I think we'll be seeing some of that work over the next few years. It's caught the attention of a couple of our colleagues in research.
Understandable. Okay. Well, just a couple more questions because I know we are past way past our time, but I do want to try. There's a really great question. We do have a question. You were referencing about an item that may be for sale, and can you clarify, was that in regards to flow cards or was that in regards to syringes?
Oh, so we have some items on our website, some posters, the flow test cards. They're like the size of a business card, so easy to have around. And we've just come out with some cards for the fork testing as a reference guide. Now, those are available for anyone to download on our website, right? But then you will have to get the card stock and then you have to cut them up, etc. So some people are saying, I'd rather just send a purchase order and just order 1,000 little flow test cards or whatever. And so we are working right now and trying to figure out how that will happen, because this is, again, at a global level. How do we get that distributed? How do we do that? So that's what I mentioned, I believe.
Okay. This question I think is also quite popular at the moment, as we all, or many of us, are dealing with electronic health records and systems, whether it's Epic or Cerner. Can you share with us your experiences? Are you incorporating the IDDSI language and terminology into your electronic health system, or how are you approaching that?
Right. So, the different systems are, vary. And then also the way that we document or where we document, whether we're on Cerner, on Epic, on Allscripts, on whatever the EMR system is, differs. So that's why we kind of individually have to take care of that. For the most part, what folks are doing is, we're at the implementation mode, and so then they just transition fully. Others will list the diets by IDDSI level, and in parentheses try to have correlate with their previous diets, but that doesn't always match up, right? That's sometimes a little difficult. So you can't say that soft and bite-sized level 6 is the same thing as a chopped diet, right? So it would be difficult to put chopped next to level 6. So what we recommend is, again, if you're transitioning, then many places are just changing the EMR completely on the transition date, and then there are reference guides all over, in the hospital, the nursing cart, at the nursing stations, at the computer stations, to be able to be more accurate. Many times, as it's the dietitian, the speech pathologist recommending a diet. For the physicians, I guess if they're going to order something regular, 7-0 would work. I guess, again, it depends on how things are worked out at your facility and what might work in your culture.
Okay. And then I'll just ask two more questions. This one in particular was just in general, what was the overall time frame at your facility to transition over to IDDSI and implement, including, working out? We certainly understand everybody has a plan in place, and we might
Right.
go down one path and have to move things around a little bit. But in general, from the time that the facility and the organization, you made your decision that you were going to move forward and then putting it into practice, how much
Right.
time overall would you say that it took?
The implementation guides that we have available on the website are based on 12 months, but that may differ. Okay. Ours at our hospital has taken a bit longer because last summer we heard Joint Commission was going to stop by. And so at that point, we had done our mapping, but we couldn't start playing around with different items because we would have to change our diet manual, et cetera, et cetera. And Joint Commission ended up arriving in October. So we had easily a 6-month delay right there. And as soon as the Joint Commission surveyors left the building, we regrouped and just kept plugging away. So I would say again, it varies. You can plan for a 12-month process, and it's doable. And I've seen it be doable. But it also depends on the time available of the folks that are spearheading the movement, and then if you run into any difficulties along the way, such as needing special approvals from administration, things like, accreditation visits or anything along those lines.
Absolutely. One thing I'll share, and quite timely, yesterday there was an email that went out from the Academy of Nutrition and Dietetics, and they're working with ASHA, and they're launching an International Dysphagia Diet Standardization Initiative, or IDDSI, boot camp. I believe there's no charge to sign up for this, so check your emails if you receive the Academy e-blast, because it looks like a very resourceful and helpful opportunity. There'll be monthly emails that are going to provide some timelines and guides for implementation into your facilities, so you can enroll in the IDDSI boot camp to help you along your path when it comes to implementing IDDSI. And so the last is kind of a combination of a question and a request, Dr. Riquelme, is in regards to, it's back to that lovely the mincer or the dicer, and using specific equipment that could be very helpful, especially to those that are in food service that are going to be preparing or are preparing foods that would fall under the IDDSI framework. Are you familiar? Is there a suggested list of equipment to consider when looking at what's going to help food service to incorporate this? And are there any videos that, especially those that are working in food service, that they could watch to see how to best prepare the foods?
So again, in terms of, I'll start backwards. So in terms of the preparing of the foods, that's where we're hoping we're going to get more chefs involved and more food service folks. And we have several chefs around the world who are quite well invested. We had along with the National Foundation of Swallowing Disorders, we held a contest last year where people sent in videos of how they're preparing foods at the different IDDSI levels during June, which is Dysphagia Awareness Month. And that was a lot of fun, and that's where we saw several chefs that chimed in and submitted videos. So once we get them more involved, I think maybe that would be something we can add, on our website, and we'd love to be able to do that. In terms of specific products, we can't. We really can't promote products, and so that's what's difficult. And that's why if we could create some kind of forum for people undergoing implementation to share and document and talk to each other, then it's like you and I sitting over coffee and sharing this new machine we just got and how great it is. That would be fine. We can't do it as an organization.
Understand. Well, again, I want to thank everybody, and for those of you that had the ability to stay on with us and learn more through this Q&A session, we do hope that you found this information helpful as you are working on your plans with implementation. I'm sure, looking back at all of those that attended today, we'll probably have several that are new and just getting started. There may be some that are in the midst of it, and maybe some that are almost there or fully implemented. So we appreciate you taking the time to attend today's webinar. Thank you so much, Dr. Riquelme. We appreciate your wealth of experience in the world of IDDSI and sharing your expertise with us. Thanks so much, everybody, and have a wonderful day.